Welcome everyone to today's DHCW Digital Governance and Safety Committee meeting. I'd like to extend a special warm welcome back to our chair, Rowan Gardner, who's just returning from 3 months sabbatical. I'll chair today's meeting and then Rowan will resume at the meeting we've got in August. I'd also like to welcome Cora Suckley, who's going to be supporting Darren when we do a couple of deep dives later on in the afternoon. And in the interest of time, rather than ask people to introduce themselves now, I'll ask them to do it when they first speak, either to present a paper or to ask a question. I've been notified of 3 apologies for absence today. Paul Evans is unavailable, but Laura Beddow is joining us to cover for Paul, so welcome, Laura. Carwyn, Lloyd-Jones and Michelle are both unavailable, but don't have any direct input to the meeting, so there's no deputy for them. A few other things I'd like to note. There is a private session of this meeting which will follow on from this one after a short break, where we'll discuss matters not appropriate for the public domain. A summary of those discussions will be reported in the next public session of the committee via abridged minutes, as we do have today for the previous one. Committee meeting papers and minutes are available on the DHCW website for members of the public who might wish to access them. This meeting is being recorded, and an upload of the recording will be made available on our website shortly after the meeting concludes. The meeting today is scheduled to run till about 3:30 if I manage to keep us to time. There'll be a short 15-minute break and then we'll resume with the private session at around 3:45-ish. I'll now move us to declarations of interest. I've received none in advance, so can I just ask those present if there's anything that they need to make me aware of before we move on? Okay, thank you. I can't see anything, so there's nothing to declare. Matters arising. I'll ask anybody if there are any matters arising they wish to bring to the attention of the committee. Again, I can see nothing, so I'll take that as nothing. We'll now move on to the consent agenda and basically the minutes of the last meeting, which includes the public and the private abridged session. So can I just check in terms of the minutes of the last public meeting? Are everybody happy there was a true record of the meeting, or is there any amendments that you need to bring to our attention? Okay, I can't see anything, so we'll take those as approved. And can I ask the same question for the private abridged minutes? Any comments on those in terms of accuracy or additional information? Okay, so we'll take those as approved as well. Next item on the agenda is 2.2, which is the forward work plan. The committee is being asked to note this forward work plan. It's available in the meeting pack, and it basically gives us a view of things that will come to this committee over the next year or so. So that's just for noting. I'll now move us on to the main agenda. And the first item there is the action log. There was just one action outstanding from the previous meeting, which has now been closed. So there's no outstanding actions from any of our previous meetings. Item 3.2 on the agenda is the corporate risk register, and I'll ask Chris Starling, our board secretary, just to take the lead on this one, if I may, Chris.
Yeah, thank you, Chair. So as you said, I'm Chris Starling, board secretary at DHCW. I'm just going to run through the report, the corporate risk register report, an update on the current position. So just to start with, to note, we currently have 16 risks on our corporate risk register. 9 of those are assigned to this committee for oversight and scrutiny. I'm going to start by just highlighting 2 that were removed from the risk register since the last committee meeting. So sustainable funding for NIAS. And I'm going to ask Darren to just expand on these and cover the acronyms in a moment, and sustainable funding for WASPI. So 2 risks that were on from a financial perspective for 2 of our national products have come off since the last meeting. I'm just going to run through the current risks that are assigned to the committee in public. Just to note, there are 4 that are considered in private session due to the sensitivities. So the first one I'm going to cover, I'm going to ask if Sam Lloyd would just give a quick update, because the remaining risks all relate to Darren's area, so I can cover them off in one if that's okay. So 0316, the technical debt accumulation, that's been on for a little while, and I know, Sam, there's been a fair bit of work to understand and mitigate. Do you want to update on where we're at in terms of risk score and the mitigation?
Yeah, thank you, Chris. And I'm Sam Lloyd, Executive Director of Operations. So this risk really encapsulates the position so we currently are carrying some technical debt within our system, and the definition of technical debt that we're using are those aspects of our legacy technology which are preventing us from moving forward at the pace that we would like to be able to do so, or pose the risk of doing that in the future. So there are a number of pieces of activity which are underway currently, which are going to address that risk. So I'll just run through the main points. So we're currently shaping up our cloud migration business case. So DHCW wrote a strategy a couple of years back, which stated that we would become a cloud-first organisation. We're now in the process of translating that into a business case and a delivery plan. We're expecting to have that case complete by the end of June at the latest. We are, of course, running the National Disease Registry, or National Disease, the NDR program, which is looking to build our national data and analytics capability. That will be moving data sets into modern platforms where analytical tools can be run against them, and so on, which is a big part of addressing technical debt in our data layer. And then there are a number of specific products and services which we're looking to modernize. So we've done some work recently looking at WPAS to understand what might be done to move that to a cloud-native architecture. We're looking also at our integration platforms, which is a key means by which data is exchanged between systems in our architecture. That's a platform which has been in place for some time, and we are looking to modernize that and move that to a cloud-native platform, which will enable changes to be made much more rapidly, and for more rapid adoption of APIs and so on, which is a core part of our open architecture strategy. We're also looking at the Welsh Clinical Communications Gateway, which is a system that manages referrals between primary and secondary care and other care settings. We are looking at strategy for how to re-platform that and again modernize it into a cloud-native application. And then lastly, the Master Patient Index, which is our main source of demographics for systems. We are again considering the future of that and building a strategy to move that to a cloud-native architecture as well. So there is a lot of work ongoing in this space which will address our technical debt risks.
Alistair, I see you've got your hand up. Do you want to come in at this point?
Thanks, Chair. Either now or towards the end. It's a particular question around our satisfaction level, Sam, that we have the necessary budget to manage the risks in the way we've set them out. And I'm thinking, for example, the HCW 0320, which is the citizen and stakeholder trust and uses of health and social care data, and the questions that are out there in the wider public sector about the Connecting Care funding for the period ahead. And I just wondered, either now or after you've finished your sequence, Sam, if you could address that particular question. Thank you.
Thank you, Alistair.
Okay, Rowan, do you want to ask a question, and then if someone's to respond, you can do both.
Thank you, David. Sam, I'm always assured that we know the technical answer to addressing the technical debt issue, and I'm well aware of the really good work that's going on. I'm interested to understand the concern that may be existing between the dependency on funding to come into key programs to enable the, for example, migration to cloud, and what that means for the timescale that we may be having to manage the technical debt risk in the business. And do you have any thoughts on that? because to some extent, Sam, this is the less sexy stuff that is the really good engine that we need to have in DHCW in order to deliver all of the tools and technologies that the wider NHS in Wales wants to consume, but may not look at the problem through this lens. So could you just talk a little bit about that for us?
Yeah, thank you. So I think both questions similarly around the funding situation. So I'll try and kind of address both. We know we're in a difficult and challenging funding environment. We've seen the Digital Priorities Investment Fund cut coming into the current financial year. It's unlikely that significant additional funding for non-patient facing activities such as the ones that we're talking about here is likely to be forthcoming from Welsh Government, certainly within the next 12 to 24 months is our working assumption. We have looked in detail at the cloud economic case, and we do believe that there is a case for moving to cloud, and that doing so will essentially pay for itself over a period of 5 years. However, it is challenging to you need to invest in order to make those changes. So the considerations that we're now making is where are we able to make efficiency savings in the short term in order to redirect those savings back into activities such as the cloud migration, and that's really the crux of the case that we're working to at the moment. We're also looking at strategy in terms of how we deliver these strategic development activities. So we've recently brought in a chief DevOps officer, Raphael Bergman, who's come in with some strategic ideas about we should be much more confident around our own ability to deliver this stuff. We should be building it ourselves using cloud native capabilities rather than expecting to bring in someone to do it for us or to buy things off the shelf. We really need to identify the things that are the crown jewels for DHCW, the areas that we really need to own and invest in, not just in the technology but in the capability, and then have the confidence to do that ourselves. So we're really working to do as much as we can within the envelope that we have, but that's not to downplay the difficulty. And there are going to be, I think, tough decisions for the organisation to make around where to how to prioritise activity and investment in order to bring some of these outcomes about.
Thank you, Sam. Alistair, do you want to come back in?
Just a real quick one, Chair. Thanks. And Sam, I really appreciate that we live in obviously in a very real and challenging financial and funding environment, and we recognise that as much as we must make progress. I do wonder how much we are therefore reassessing our management of the risks, if funding in order to be able to deliver on time or deliver in the way that we believe we need to, or might be even the most efficient way, is potentially undermined by the lack of funding or the change in funding fund stream. So it's really just to make that point about the need to review risks in the light of such cross-cutting impacts. But thank you.
Rowan, I see your hands up. Do you want to come back in as well?
Just a quick one, because I think Sam made a very important point around prioritisation. And so, Sam, I was just wanting to understand, I know Marilyn is always very good at being the first to do this, but that prioritisation, must be made as a part of a collaborative discussion with the wider service. This risk is on our register. But actually may ought to be on the wider registers across boards in Wales. Who knows? I'm not qualified to judge. But how are we exposing the dependency of this risk to the wider health boards, and what discussions are taking place between DHCW and colleagues across the service, so that we can take those prioritisation discussions informed by wider concerns, and with a confidence there's an understanding about the consequences of those decisions to the wider service. Can you talk about some of those forums and conversations and where they're being had?
Yeah, so there are a number of forums through which we're having those conversations. So we have regular exec-to-exec meetings with each of the health boards, which are obviously the whole exec teams that get together, and a big part of that is agreeing on IMTP priorities and aligning on them for the year. We're also starting to put some additional, and just to take us, there are existing mechanisms in place as well around things like the Service Management Board and the National Service Management Board, which is our sort of formal structure for reporting on our, the delivery of our products and services to our customers, and to take feedback on how that is operating. But then at the more strategic level, we're also looking at putting additional governance in place around the API's delivery program. So we're about to stand up a sort of cross-organizational governance framework that will cover that. I'm also in the process of, now my new senior leadership team is in place, of liaising with the directors of digital to have more regular touch points between our technology teams to kind of agree on priorities at that level as well. So plus we have the engagement team that sits in Ivan's area who are having those conversations regularly with our external stakeholders. And just one more point, if I may, on the earlier conversation around prioritization internally and funding and so on. All of these aspects that I just mentioned, all of these initiatives, plus others around the target operating model, are being combined into the Building Our Future transformation program for DHCW, which Claire is leading as the exec leader for Mission 5. So, we're taking a programmatic view to understanding what it is that we're trying to achieve, and then structuring ourselves to delivering it.
Thanks, Sam. Just before I bring Marilyn in, just for the sake of clarity, can you just confirm that given the funding situation that we have, which we've just been talking about, the risk as it's captured represents the risk, given that we don't have funding to do anything this year for more, reducing the risk? Is that a fair statement?
I think we don't have additional funding to do anything this year, but we are fully intending to make progress. So, for example, okay, we're looking at the integration hub modernisation work at the moment. So we're absolutely intending to make progress. Okay. From within our current
within our resources.
Yeah.
Okay. Yeah. Fine. Good. Thanks for that clarification, Marilyn.
Just along the lines of we've already been talking about, really, also as well within the message about saying that if we don't do these things, because we talked about the benefits of all these things if we collaborate, but also perhaps letting the health organisations know that if we don't, where that might leave us in regards to, the future projections as well.
Yes. Good point, Marilyn. Sam, have you finished, or do you need to hand back to Chris, or do you have something else you wanted to say?
No, I've finished. Thank you.
Okay. Back to you then, Chris.
Thank you, Chair. And just to make a comment on the financial position, I think there is a national focus on value and sustainability, particularly through the lens of addressing variation. The IMTP guidance that came out earlier this year talked about variation. It's been reinforced from Judith Paget, the Chief Exec of NHS Wales, on a number of occasions, and they do talk about a once for Wales approach. So I think, considering some of the opportunities for us from a risk perspective, I think looking at where digital can address variation across the system is something that we are looking at, and something that Ridian often talks about, I know. So in terms of the thank you, Sam. In terms of the other risks that I wanted to highlight for the committee, a number of them the committee members will be familiar with. They've been on the risk register for a little while. So two of those are kind of linked: 0263, the data functions, and the 0320, the citizen and stakeholder trust in the uses of health and social care data. So I'll ask Darren if you can update on those, in addition to the 0296, the allergies adverse reaction risk, and whether Darren or Ridian want to comment on 0300, the CANIS screening palliative care risks.
Thanks, Chris. I'm Darren Lloyd. I'm the Associate Director for Information Governance and Patient Safety. Chair, I'll have to apologise in advance. I'm dropping in and out of Teams today for some reason. I think I've had a BIOS update this morning, and it seemed to playing havoc with my laptop. So apologies if I suddenly drop out. So 263 in terms of data functions, and then the 320, which Alistair referred to, actually 320 in terms of the citizen and stakeholder engagement. We are assisting Welsh Government in trying to improve on matters, certainly in terms of the data functions element, because for some time we've understood that in order for us to do those things that we need to do with specific amounts of information or data, especially when we're talking about indirect care of uses of data for service improvement, performance or other related matters, we need a legal basis for doing those things. Welsh Government, it's in Welsh Government powers to instruct us to do those things. We are working with Welsh Government to understand what they have as a priority in terms of the policy areas to instruct us to process data for particular purposes. Those clear instructions aren't always apparent, and it can leave us in a bit of a no man's land position sometimes in terms of whether we do have a clear mandate to actually process data under certain circumstances. So Welsh Government is still working that through. There's a focus on primary care data. There's also a focus on secondary care data as well, but the priority is about understanding how we acquire data, but with the right legal basis. So myself and my team are working hard with Welsh Government to try and establish that together with Rachel's team as well, because the acquisition of data, of course, brings in processing requirements, but we need the legal basis for doing that. It's not different in Wales to England. It's a UK-wide element to it because we need a lawful basis for processing. Our functions are set within our organisation. That's great because that's part of our establishment, but it's about the lawful basis for processing data. So we continue to work hard with Welsh Government to try and push that through. The citizen and stakeholder engagement element, there are components that are being taken forward at a policy level, but not whole scale. That is, I would suggest, is kind of paused slightly, because there's again, we're coming back to the same issue. There may be a funding consideration of Welsh Government about going out to the public more generally. And again, I don't want to steal Rachel's thunder in terms of research and innovation, but one matter in terms of find, follow up and recruit, the policy lead is doing some stakeholder engagement to understand the impact of a find, follow up and recruit service on the public, i.e. we're going to come to you and ask you if you want to be part of a particular research study, etc., etc. So there's a specific piece of work going on there, but that's confined to one policy area at the moment. That needs to be expanded out in terms of DHCW's functions and the intention and the strategy on how we're planning on using data more globally and more openly across all of the different systems and services that we provide, and the rest of NHS Wales and social care provide as well. So there's a much wider piece of work that is paused because of specific financial and resource constraints, effectively. There's those two. Are there any questions on those two before I move to the other? No? Okay. The allergies and adverse reactions risk, we have some light at the end of the tunnel of those, because we're coming together with a clinical data engine or clinical data repository and a medicine management function that will contain all of that information. So that work is ongoing, and how we consolidate information from different sources to have one source of the truth as some of that information, which will contain allergies and adverse reactions. So the mitigation of this particular risk is ongoing, but it's predicated on the fact that we have another large silo and repository of the data that means all of our systems and services can plug into, so that we have one source of the truth. So that is ongoing as we currently stand. But it won't affect the risk yet until we get further down that development. And Rydian, I don't know if you want to talk about 0300. You're better placed than myself on that one.
Hopefully you can hear me, David.
I can.
Hi, Rydian Hurl. I'm the Medical Director at Digital Healthcare Wales. I'm just going to make a comment on the allergies and adverse reactions. The fact that it's actually an electronic record has made it a lot safer than the fact that we had it written on pieces of paper. So although it's a risk, it's actually safer than it was. Moving to CANISC, independent members will be well cited on the issues we've had with CANISC and the transition off it. The current timeline is to decommission for live colposcopy services, which is the screening element of it, in Q3. We made very good progress. I had a cup of coffee with the lead for Public Health Wales yesterday, updating her on what is ahead of us in terms of those dependencies, clinical sign-off, and a technical integration of the images of the colposcopy clinic into the electronic health record. Regarding palliative care, good progress on that in terms of the delivery of the user interface to allow caseload management. This is being clinically led by Victoria Wheatley. She's a palliative care consultant currently in Hywel Dda now. She leads the digital element of the end of care life board, end of life care board. It's one of those two. I may have got it the wrong way around twice. And they're in the current, they're in user accepted testing for the caseloads managed element, which is the last bit of that jigsaw. That's my update.
Thanks, Regine. Darren, did you want to come back on anything, or should we move to Chris?
That's fine from my perspective. If everybody's else is happy with that.
Can't see any questions. We'll go back to Chris.
Thanks, David. Yeah, and Darren, do you just want to comment on the two risks that have been removed, WASPI and NIAS, and just explain probably what they are and why they've come off from a funding perspective?
Yes, thanks, Chris. Sorry about that. You did mention it earlier. The context around this was that we did have those two risks. One was about us taking the Wales Code for sharing personal information into a code of conduct position. I'm pleased to announce that from the core funding that DHCW has, we're investing in actually developing that service now into a code of conduct with the Information Commissioner's Office. So we're proceeding with that. We're developing a resource to actually put that forward, and we are now engaging with the Information Commissioner's Office because now we're into a 6 to 9 month engagement on what we've proposed to ensure that we make the grade effectively, because having an information covenant, an ICO stamp, is obviously a difficult bar to actually achieve, and we will hopefully be the first one in the UK to achieve that. The team are working really hard at the moment, so we were able to take the risk off because the funding element for us to proceed on that was forthcoming. So we have a assigned budget in order to take that forward now over the next few years and the period in order to get us as a code of conduct effectively. So that's WASPI. And the other one in NIAS, very similar as well in terms of allocation of core funding in order to fund the system, not necessarily the full service, but the system itself. So we were able to reprocure, establishing through our current contract, but giving us some certainty now when we have to go back out to the service, back out to the potential suppliers as a full reprocurement of NIAS in the next 18 months to 2 years. So we are now planning our reprocurement path, planning our requirement set in the eyes of aspects of what Sam related to, actually open architecture, API management, those type of thing, and what a new NIAS, the National Intelligent Integrated Order System, might need to look like and future-proof us over the next couple of years. So the funding constraint for the system has been removed.
That's good news, Dan. Chris, anything you further want to add by way of a wrap-up?
Yeah, thank you, Chair. Just to wrap up, so just asking the committee to note the existing risks assigned to the committee and the mitigation actions, noting the two myths removed and importantly, I guess, the core funding allocated there in the context of the funding pressures and constraints generally, and we'll take on board the comments around that and review the risks in that context.
Great, thanks, Chris. If there's no further questions on the corporate risk register, I'll move us on to agenda item 3.3, which is the Incident Review and Organisational Learning Report, and I'll hand over to Keith Reeves for this item.
Okay, thank you, Chair. So I'm Keith Reeves. I'm Service Management Team Manager and also Deputy Chair of the Incident Review and Learning Group. So we've produced our annual report. The annual report is under Appendix A of the papers. For this year, we've actually changed the format of the report just to make it easier to read and a lot more accessible. So whilst it still follows the same approach that we've included in previous reports, moving it into presentation format actually makes it just that much easier for everybody to be able to view it and to read it. What I'll do is I'll just go through some of the key highlights and then take questions afterwards. So as I said, this is really year 4. We've just started year 4 of the Incident Review and Learning Group. When we first set up the group, we envisaged sort of a 3-stage approach over the last 3 years, with financial year 23-24 focusing more about embedding the culture of improvement and the culture of learning within the organisation, so that it then helps to underpin the strategic missions of within the IMTP and of DHCW. So some of the work that we've been doing this year has actually been more focused around development of a forward work plan, as well as sort of identifying the priorities of the group going forward, and continuing that embedment and the embedding of that learning and that improvement and how we take that forward. Some of the work that we've been doing towards the latter end of the year has been more about not just focusing on incidents, but actually starting to focus more on all areas of learning. So whether it's audit reports and audit reviews, or it's program reports, post-implementation reviews. So it's building up that culture, it's building up the sharing of those lessons, which has helped to really drive the group forward. The format of the report, as I say, hasn't really changed. It's still focusing on the 4 key areas of the group. So the reporting, the reviewing, the learning, the improvement. So under the reporting side, there has been a general increase in Q4 within the inquiries. So as we mentioned at the last time that I presented on this, there has been that increase because of the work that's been ongoing with the NHS Wales app. What that has led to, though, is that it's meant that DHCW can look at solutioning of the ongoing support, and there's been work ongoing around how we resource it, a lot of work within the programme and wider within DHCW about recruiting key individuals into the various areas. It's also helped us to identify areas where we can improve the general support model and how we provide support to patients and to the public, as well as some of the technical developments that have been driven forward, especially around identity verification and also the shared access. Some of the work we've also done, I've got to make mention of this, is that the service desk has started to do a lot more of reporting and analysis, and there's more reports going up the line into the management board to sort of underpin some of the decisions that are being made around how we support this this product going forward. And also it's allowed us to do a lot more sort of education and knowledge sharing within the desk to be able to provide a little bit more resilience around when incidents or when calls come in, the desk are able to then cope with those and be able to understand how to resolve those much more effectively. Under the reviewing side, there has been a drop-off within Q4 on the reviews that we've received. This has just been the natural business within the group, where we've started to look at more in-depth reviews. And what I've done is, again, just provided a very brief summary. So across the year, we've had 27 review reports come through. That's been split between application incidents, infrastructure incidents, but also the audits, the surveys, the thematic reviews, and the lessons learned from programs. So it's going back to that building that culture that I mentioned right at the start. We then have a general comparison against previous years, and generally, yes, we're slightly down on previous years, but the approach that we've taken has meant that things like thematic reviews, where you have multiple incidents, we're able to then build up a bigger picture of some of the contributory factors that have been identified. and also allowing us to identify through risk-based audits additional areas where we can improve. Onto the learning. So I've included some of the examples of the actual lessons learned that have been coming through. So it then gives the indication both to this group and to anybody reading this report that we are taking this seriously, and we are looking at, okay, well, what do we learn from that incident or from that program? So the two that we've included in there have been as a result of, one is as a result of the NHS Wales app, and how that was in the impact on the patient when they lost access to that service and to My Health Online. What we've learned from that to be able to push that into, okay, well, how do we take that forward? How do we learn from that? The second one was actually as a result of the change enablement or change management audit that was undertaken. This was a recommendation that came out through a number of the reports we've done previously, and this was again evidencing that actually there's still a lot of improvement we can make around how we manage changes, and whether the robustness of the documentation that we've got, the training that we provide to our change managers is enough, but also to then pick up under additional improvements around how we deliver that training, how we make sure that we're communicating with the change managers where there's a change in process. One of the closed action that was mentioned earlier was around the contributory factors framework. So in the last meeting, we've taken that forward. We are looking at how we can review the wording to make it much more accessible. But for the benefit of this report, we've maintained that consistency throughout. But what we've also identified is that actually if we can use this framework and make it more digital centric, then it actually gives us a starting point to actually be able to push out to the other health boards and potentially wider within the healthcare industry about how we can manage contributory factors from a digital perspective. So we're sort of trying to lead the way in this, that whilst we've taken what is essentially a clinical tool set, we're adapting it to be able to fit into the digital world. And so some of the changes that we've made are going to be more about making it much more user friendly. But generally speaking, the format will remain the same. So the contributory factors, yes, we've noticed increases within what would be the departmental domain. So this is around the infrastructure, the applications, the software and the data. But also there's been an increase in identifying around the supplier management side and our general stakeholder management within the individual health boards. So whilst we've seen that increase, we've been able to identify it, we've been able to put improvements in place so that over time there will be that general decrease, which is what we've noticed within the active domain. So within the active domain, there's actually been less around sort of mistakes, the human error type factors, which is reducing the number of incidents that we've actually received within that sort of factor. That's then linked back to how we're delivering training, how we're improving on the processes, and how we're working generally as an organisation, which is always a positive. And then the final section, which is around the improving. So taking the feedback from previous reviews, we've started to align the improvements to the missions within the IMTP. So a lot of the improvements, in fact, probably all of the improvements that we've got on at the moment, are primarily focused around Mission 5. So again, it's the work that Claire has been doing in that area. So, but it also means that the improvements can then also be linked across the other missions as well. So we can make improvements around how we deliver products. For quarter 4, we've identified 4 new improvements that we're looking to implement. One is around an enhanced learning program. and this is working between patient safety team under Darren and Public Health Wales. The second is more around the clinical strategies and the improvements that we're going to be identifying through the work that's going to be going on within that area. And then the last one, which is actually quite a big improvement for us, is the collaboration between clinical informaticists and service management and within the operations directorate to have a better understanding of the clinical impact when we're making changes or when a system is failing. So there's a lot of work going on in that area that we're trying to drive to actually increase the awareness that actually digital does make a difference. One of the improvements that we have completed for this quarter is around that contributory factors framework, and generally across the year. I mean, we've looked at incident review tool sets, we've looked at the promotion of the lessons learned, we've looked at the embedding the lessons learned. Whilst we've completed those improvements, it doesn't mean that it's going to stop. What we're going to be doing is working with the likes of the quality team around how we do effectiveness reviews, so that we can then go back to these improvements and go, okay, has that stuck? And I know that there's some work that I'll be doing with Paul Evans and with Laura around how do we do that? How do we report on that? I think that's pretty much everything that I wanted to cover off.
Okay, thanks, Keith. That's very comprehensive. Anybody got any questions for Keith? No, you've done an excellent job, Keith, in keeping us abreast. I'll really look forward to the contributory factors framework in future meetings, where we can see the benefit of the work you've done on that feeding through into some incident learning. Ridian, you've got your hand up. Do you want to come in?
It's just a comment, David. Firstly, just thank Keith for putting it together and taking us through. And the second is just to emphasise that every day is a learning day, and we're always learning at Digital Healthcare Wales. You know, where we make errors, we put our hand up in an open and transparent way, and we do everything we can to mitigate the risk of these things happening again.
Yeah, really good point, Ridian. Okay, Keith, thanks very much for the report. I'll now move us on to section 3.4 of our agenda, which is the assurance reports, of which we've got 4. The first of those is the Information Governance Assurance Report, and for that I'll hand over to Darren Lloyd.
Thanks, David. So I'll just spot some of the highlights within the report. I won't go it verbatim, but if anybody's got any questions after reading or any queries as a result of my conversation, then please feel free to stop me. So as you probably worked out, we've now re-emphasised the components of our new strategy within our report, our 4 aims around some of our statutory functions and then some of our outward facing elements. So it's based on those criteria. Part of the report also demonstrates where we've achieved certain actions against our previous information governance toolkit assurance. I'll come on to our next iteration of our information governance toolkit assurance from a corporate perspective shortly. Our performance again, some spotlights around some minor incidents and then some elements around our FOI compliance as well. We're noticing they are creeping up slightly. That's possibly because of our statutory responsibilities and the fact that what's happening is possibly within the spotlight a little bit more because of the good work that we're doing across public services, etc. So some of those type of FOIs are commensurate with those that type of activity, to be honest. The other FOIs are generally things where we're getting requests for certain information about our IT, our infrastructure and our services, those type of things. So our FOI process is working well. We often have to come into the business then to answer some of the questions. In terms of the Appendix B, there's a demonstration of the amount of data protection impact assessments that we have, and that we have a very fast factory line actually of data protection impact assessments. 31 of them in progress, 10 of them started and 10 of them signed off. with all of the major components of our systems and services: Welsh Clinical Portal, Welsh Patient Admin Service, Shared Medicines Record, Laboratory Information System, and the National Data Repository as well. So that's the type of thing that we're doing. We're involved in quite significantly in the assurance process to make sure that from a confidentiality and privacy perspective, we've covered those elements off and we've done the proper risk assessments, which are, although I'm slightly biased, very thorough. And then in terms of the other elements as well, showing the amount of calls that we're taking actually across some of our services in terms of our Data Protection Officer service. Cora's here today, she'll speak about that in terms of the deep dive a little bit later, Information Governance Toolkit, and then everything else that we do as well. So our calls are increasing as well in terms of the amount of activity that we do have inward and outwardly as well into other services. And we've split them up slightly just to demonstrate some of those other component parts, which I think is quite important and reflective of our responsibilities. And then some elements on our recent updates. The promotion of an information governance policy for Wales. Ridian has helped to champion that and the communication across into medical directors to try and to allow organisations to adopt an IG policy across Wales. And that's been as part of a combined effort through the Information Governance Management Advisory Group across Wales. So the creation of all Wales policies, which we think are very important. I've mentioned about WASPI and the code of conduct, so there, and then some of the information governance toolkits elements will come in as part of the deep dive as well. And then our 23-24 toolkit submission as well. Some of you may see that we've got some statistics around that. One thing to note is, as part of the toolkit development, sometimes we move not the goalposts, but we move the question set a little bit in order to challenge organisations, including ourselves, against our compliance. So you will see some of the variation compliance from one year to the other, not because we've necessarily gone down in compliance, because we've shifted or slightly altered the question set to allow us to actually adapt either to elements that are going on with the law or elements of where we feel that there's a market improvement required in organisations. So we don't do that all the time because that kind of upsets the kind of equilibrium of reporting and assurance within one organisation, but we do it as we learn. Keith came on to talk about a lot about learning. As we learn, now we can actually pull into certain areas of compliance and allow boards like ourselves and committees like ourselves to understand where there's maybe associated risks or where we can actually bring forward some actions in good governance and confidentiality and privacy, etc. So that's just a quick run through of the report. All of those key components on there. And again, I said it last time, it just gives a relative indication of how much activity is coming through this kind of the information governance framework responsibilities that we have.
Excellent, thanks, Darren. Have we got any questions for Darren on the report? Okay, I can't see any hands up. I have got one thing I was going to ask Darren, if that's all right. On the IG toolkit paper, in panel 4.6, against training, we are 90% against our minimum requirement, but we've exceeded it as well. So I was slightly confused by how we managed to sort of not quite hit the minimum, but exceeded at the same time. Could you just unwrap that for me, please?
That's a slight change in the question set, effectively, from one to the other. So,
okay,
it's not an anomaly in the question. It's the fact that we've managed to exceed before we get to the minimum element. It's about one of the key questions in them. We might find that across a number of different organisations that it's just a slight anomaly in the question set. I think Cora might be able to cover that off in terms of the deep dive slightly later, but it's just a slight anomaly on the training element. That's all, the way we've asked the question this year, effectively.
Yeah. And just for clarity, the 90%, is that just because not everyone's completed their mandatory training, or what's behind the figure?
No, the figure themselves are quite one-dimensional. It's about the completion of the question, not necessarily the completion of any statistics, i.e. in terms of performance, those type of things. Fine. So that figure doesn't necessarily give a high level of indication as to other elements where we might have gained 100%. In fact, our information governance compliance is really very high in the organisation. It's something that Ridian
Yeah.
champions on a very regular basis, and I think we're 97% across the organisation actually in terms of that. So
yeah. Okay, thanks for the clarification, Darren. Thank you for the report. I can see no other questions, so let's move on to the second report, which is the Informatics Assurance Report. And for this, we'll turn to Laura Beddow.
Thank you, Chair. So I'm Laura Beddow, Quality Manager. I'm also the Chair of the Wales Informatics Assurance Group, WIAG. A few highlights. This quarter has been extremely busy. WIAG's held fortnightly, and we've had to extend some purely to accommodate the volume of projects that's coming through the door, which I think demonstrates the work that's happening, I think, as other people have mentioned, in DHCW at the moment. We have, in section 5, I think the main point that I wanted to raise was about the power apps. That's the key change that's going to be happening within WIAG. So we've had updates at WIAG. So we're working closely with the Centre of Excellence. They've come to WIAG in May, and we also presented at the Programme and Projects Professional Network Group to make sure that all the programme managers are fully aware of what's happening. May, we have a full end-to-end run through booked with Ridian, and then in June we have the assurance leads who will be doing the full end-to-end process again as a test, as the final pilot of the project. So throughout this month and next month, we're having conversations with the project managers who will come in to say, to understand exactly where their go-live dates are and understand whether they're going to be running on a current process of completing an assurance quality plan, then a safety case and readiness report, or whether they have enough time to wait until then the Power App goes live. So we do have 19 assurance quality plans that are currently going through the process. So we know we'll have a minimum of 19 projects that will be running through our current process. So we've had this conversation with the WIAG assurance leads. We know that we may need to make some slight tweaks when we put the agenda out so everybody knows exactly which process they're following. But we're all confident that we'll be able to manage that process. We're very comfortable with the current process, and so we know we can manage that, and we're quite happy that we'll be able to continue when we're running the two systems for a short period. We do have a series of workshops or training sessions planned, which we're going to roll out both for assurance leads and for project managers. We also have training videos ready and waiting, so people can just jump in, and when the Power App goes live, we can just direct them to them, but there'll be one-on-one training as well. And I thought for this group, it would probably be Q2 where I'd be able to then start giving you some sort of really meaningful data about how we're working with the two systems, how many are going through, and we'll start to begin feedback then probably more by Q3, we'll get some really good feedback then on how it's working and potentially any changes and iterations we need to make to it.
Great, thank you, Laura. Any questions for Laura on the Informatics Assurance Report? Ridian.
As just an observation, Laura very kindly steps in and chairs the programme for me because, as you can imagine, can't attend everything. She did it with great skill and with a lot of patience, I might add. So I just wanted to record my thanks to Laura.
Okay. Yes. Thank you, Laura. Laura, just an observation from me. I think we touched on the Power App a couple of times in previous meetings, and it's going to be more efficient for us in terms of the amount of effort we have to put in for managing the process. Should we also expect that there be a shortening of the time it takes for the approval of these requests, as well as a slightly reduced workload for you and the team?
I'm hoping that we're going to be streamlining the process slightly. At the moment, when a project manager comes in with an AQP, there's kind of a stop, and there's like the gateway. Then you can't move forward with a safety case until that one has been fully signed off by 20 assurance leads. That isn't going to be the case with the Power App. Obviously, we still need the 20 to assure, but it is going to be that pause once, so say somebody from Information Governance has requested a DPIA, it can be processed. And as soon as it's approved, it can be approved, immediately. So that part of it will definitely streamline.
Great, that's good news. Okay, well, thanks for the report, and we'll look forward to further updates during the year on its rollout. Okay, I can see no other hands, so we'll move on to the next report then. And this is the Informatics Services Assurance Report. And for that, I'll hand over to Rachel Powell.
Thank you, Chair, and afternoon, everyone. I'm Rachel Powell, Associate Director of Information Intelligence and Research at DHCW. So I'm going to start with the Information Services Assurance Report. And one of the key things just to highlight first and foremost, and members will have heard me talk about this quite a lot, so I'm not going to repeat, but just in terms of the information and analytics strategy, which was a suite of 3 strategies from the clinical director that was published last year. We spent the last quarter spending a bit of time looking at the milestones in terms of a delivery plan and what we can put forward for the IMTP for 24-25. So that's been a major activity. But just in respect of Q4 of last year, all milestones were delivered and on time as well. So that was good performance overall for that area. Since February, the ISD, or Information Services, Assurance Group received 23 assurance quality plans, 4 safety case readiness reports and 8 change requests. And just to reiterate, from an information assurances perspective, that's really to review the quality of that documentation and to assess for any information services impacts and to provide ongoing advice and support in respect of those areas where we can help to make that more robust. We've previously reported on the successful migration of all the ISD servers as part of the Data Centre 2 transition project, and we're continuing to work with the project in terms of the ongoing plan. So that's been really successful to date. And equally, the information assurances, the assurance framework for Power BI development, which is part of what the information services team have put together, that's been published, but one of the pieces of work have been taken forward, because obviously for all new publications in that space, that assurance framework is very prevalent and all things must go through that assurance framework. But we've got a piece of work that I reported on at the last committee in respect of how we're going to retrospectively review all things that have been published under those licenses. So we've issued something to all Power BI Pro license holders to say we need to clarify and we need you to confirm your adherence to the assurance framework that's been put in place. So we're doing a retrospective audit and that, and also supporting teams where we can to ensure that they're taking forward that framework. The paper, I'm not going to go into all of the detail there, but the paper lists some of the developments from the primary care information portal, and particularly in respect of year end, there's been quite a lot of developments to support general practice and in their year end report, and so some useful developments undertaken and published in that space. And 3 members of the information services team have gained safe research accreditation from the Office of National Statistics as well. So wanted to report on that because that allows them access to census data, and it opens up some opportunities in respect of what we can do in terms of accessing that data and further analysis that we can undertake using that data. So that's really useful. And then finally, the last really positive thing to end the update on is in respect of a recent external ISO 9001 audit that was undertaken with the team. So that's in respect of quality management systems, the standard for that. And there was no recommendations. We received a glowing report, and I passed on my thanks to the team as well, because we had some comments back from the external auditor to say they were really impressed with the standard of documentation and the evidence that we provided in respect to that audit. So a really positive thing to report in terms of information services assurance in that regard as well. And then no risks and escalations for information assurances to report at this stage to the committee. So just asking the committee to note the report.
Okay,
take questions.
Thank you, Rachel. Alistair's got his hand up, so we'll go to Alistair.
Thank you, Chair, and thanks also, Rachel. Very interesting to see what we've been doing and success in a number of areas. I was interested very much in what we're describing as the redesigned primary care information portal, and we describe it in positive terms. It sounds very positive, improved functionality, has assisted practices in year-end processes and so on. To what extent are we actually asking the users of the system in order that we're describing their view as opposed to describing our view?
Yeah.
And are we actually asking them for ways in which we could make it work, even better? Is there that level of, two-way engagement? And be interested in your thoughts on that. Thank you, Rachel.
Yeah, that's a really good question and a fair challenge, Alistair. And yes, is the answer to that. So we spent quite a bit of time developing a refreshed version of the primary care information portal and piloting that with some practices too before we launched it and ready to adopt it around Wales. But we do receive ongoing feedback, and we've got a dedicated email address that the team are constantly encouraging, any queries and any feedback that we can list and really incorporate into our ongoing developments for that portal. And we've got regularly report to heads of primary care, etc. So we are working quite closely with primary care to receive that feedback. I would also add though, so as part of the information and analytics strategy, one of the areas and one of the things I've been reporting on internally recently actually is we've set ourselves, one of our strategic aims is exactly around that, incorporating user feedback and ensuring that all of the work that we're spending our time on developing and publishing, etc., it is delivering value in that space and it's meeting user expectations. And we've made a commitment for all products that are published within information services, be it primary care, secondary care dashboards, work that we develop on behalf of Value and Health Programme, etc. All products that we publish will have an opportunity for user feedback to be captured and fed back, so that there'll be no anomalies. We'll capture everything, good and bad, and that puts us in a good position as well to work closely with the likes of Darren and team when we've got a strong case to say, well, products have been really well received, but what users have actually said to us is it would be a really good enhancement if this data element was brought forward, because that would help us to understand the impact on X, Y, and Z. So we want to receive that feedback, in all honesty, and we constantly want to improve and iterate our services accordingly.
Thanks, Rachel. Yeah, just on that topic, Rachel, I had a question as well, which is how widely used is it at the moment, and what's the rollout plan?
The portal or the
portal.
So all general practices within Wales have got access to the primary care information portal, and predominantly it's a tool to support general practices in their reporting requirements.
Okay.
It's also available, so it has some other users, but different access and permissions, so practices can see their own data, clusters and cluster leads can see it at an aggregate level for that cluster, and some of our colleagues within Welsh Government have also got access to the portal, but again at an aggregate high level, so they're not seeing necessarily the level of detail that practices would see. But the portal is quite it's a bespoke tool. It's got a number of different tiles and a number of different owners of those tiles, so different areas, different parts of the portal have been developed for different purposes, and they have different users, etc. So it's quite a big reporting tool that's used for primary care.
Okay, thanks, Rachel. And just for clarity, whilst all have got access to it, are all the GP practices across Wales using it on a regular basis?
Yes, because it helps they use it as part of the GMS contractual reporting requirements. So as I say, this is a tool very much developed for their use and to support them in their reporting requirements as part of the GMS contract. Great,
excellent. Thanks, Rachel. I can't see any other hands up, so can I ask you to move on to the next report then, which is the Research and Innovation Strategy Assurance Report, sorry.
No problem. So yeah, just very high level, and there's quite a lot of detail in this report, and I wasn't purposely going to go through all that detail, but I wanted to give a flavour of some of the activity, because I'm conscious we talk about assurance at such a high level, and sometimes it's difficult to appreciate the granularity of some of the work that's happening on the ground. So there's a flavour of that, and I have a reason why, and I'll come on to that. But just at a very high level, again, all research and innovation milestones delivered for Q4, and again, compliance and achievement across the whole of last year. We delivered all of our milestones on time, so that was really positive to note. And then the committee will also note that we've previously spoken about the Research and Innovation annual report, which was a good collection of all of that activity over the last year. and again, trying to give a bit of scope and breadth to the range of activities that we've supported. And I think it's useful for our partners. That's what they've reported back, that when they're trying to get their head around what DHCW does and who we are, and then when we're talking about research and innovation opportunities and some of the assets and capabilities that we've got, it's difficult to talk to that sometimes with the time slots we have available on agendas and conferences, etc. So having that resource and that report is useful for partners to be able to peruse and see the types of things we have and can support with. So just the way we've structured the report, if I start with resource, and then I've previously reported that the teams have developed and have been piloting a costing mechanism which have been taken forward, and that's really to cost recover and to build some capacity within the team. We've spoken about this previously to say, the research and innovation endeavours historically have been on an ad hoc basis and on a best endeavours approach, where we have a dedicated research and innovation portfolio within where IMTP. It's a strategic direction for the organisation, and it's really important that we've got mechanisms to build capacity and to cost recover for that work in the right way. So we've been taking that forward. We've also made some substantive appointments to the team, which is really good. So we've got a substantive head of research and innovation and a research and innovation support manager in post now, and taken things forward wonderfully. And we've also secured some additional resource from one of our main partners, Healthcare Research Wales, and that's particularly to bridge that gap between Healthcare Research Wales and DHCW, but also to support us in the find, recruit and follow-up work that we've been taken forward. And we've got that resource secured for the next 12 months as well, which is really, really positive. In terms of governance, we've got an operational and engagement group, which I chair on a monthly basis, and that's an internal group that's got representation from across DHCW, and that feeds into the Research and Innovation Board, which we held this morning, and that's chaired by Rydian, our Executive Medical Director, and Darren's a member on that board as well. And some of the activities that I mentioned, I wasn't going to talk about in detail, but there was a reason for inclusion. Those are the types of things that are discussed at both the operational and engagement group and the Research and Innovation Board. So I wanted to just show for continuation that the types of things that are discussed in detail, and we get some really good challenging debate in those groups to assess whether, Darren's looking at it from a legal perspective and making sure that we've got all the right checks and balances in that regard in place. We're looking at it in a capacity and capability perspective, and also is the strategic fit and alignment to the things that we're taking forward. Does this fit with the overall direction of the organisation, and are these the types of activities that we should be supporting? So that's the kind of things that's being discussed in those groups. In terms of engagement, we spent a lot of time plugging DHCW and the research and innovation function last year, and we've done some work with the internal engagement team in terms of reflecting on what activities last year and taking a really honest look in terms of what worked well, what didn't work well, what's our plan going forward, and what are those really specific messages that we want to nail with particular stakeholders, and setting out some plans in terms of enacting that. And just to update on some of the activity from the last quarter, we've been working really closely with Welsh Government in respect of some of the international missions that they've been leading. So the team was in Belgium in February as part of the Medvia collaboration. So Medvia is the life sciences equivalent of MediWales within Wales. And a small delegation, including DHCW Research and Innovation, went out to Brussels to speak with colleagues about some of the data and digital assets that we have within Wales, and how potentially we could harness some of the collaborations with some of our international partners, particularly in Belgium. We also attended and presented at BioWales London in February, and we've got some opportunities that have come to us as a result of that engagement, which is again really promising, and something that we've been reflecting with the engagement team, how we can track back those engagement inputs and what work we're taking forward as a result of that. And then lots of ongoing discussion with the ABPI, so the Association for British Pharmaceutical Industry. Quite a lot of feedback and input in terms of the find, recruit and follow-up work in particular. They've got a vested interest in that, and understandably so. So keen to understand from their perspective what they want to see going forward. And then we've also been taking a bit of a leading position with our WIDI colleagues in terms of the innovation training for Wales. And that was a direct ask from the Innovation Leads at Network for Health and Social Care across Wales, in terms of what DHCW could do to support growing the culture and education around innovation. And we've been supporting an innovation framework in respect of that as well. So key activities then, the Find, Recruit and Follow Up business case, we did complete that in Q4 and we issued it to Healthcare Research Wales. That's been a big focus of the team. I did want to caveat that and say, when we originally were asked to undertake that piece of work last year, I think it was a precarious financial situation then. I think even more so now. So I think throughout the course of the year, as we were developing that work, Healthcare Research Wales were quite honest and said that the funding arrangements are looking less and less promising, but they asked us to complete, and we have completed that work, and we've got that ongoing dialogue with Healthcare Research Wales. But interestingly, as a result of completing that and looking at, there's always different opportunities coming up, and I think it's always it's good to be ready, and it's good to be in a position where we know what the ambition is and where we'd like to set ourselves, because, and I'll have to consult my notes because this is a terrible acronym, but VPAG, which is the Voluntary Scheme for Branded Medicines, Prices, Access and Growth, that includes funding over 5 years to fund, to drive forward UK innovation, sustainability and growth, and particularly in the area of commercial clinical trials, which is obviously where our Find, Recruit and Follow Up work has been focused. So we're working with Healthcare Research Wales to see how we can utilise some of the learning and work we've done for Find, Recruit and Follow Up to meet the requirements of that VPAG funding and develop some digital tools in respect. So we're still very much working to that agenda, and I'm happy to give updates to the committee as that proceeds. And just to finally to end on the risks, so sorry to end on a slight down, because I think there's been so much positive work happening in this space, but funding continues to be a concern in respect of, we know we're working in a landscape where these funding opportunities that we have to be prepared to receive them, and it's very iterative, the work that we're taking forward, and we have to be responsive to that. I think we're quite comfortable in that space. We've also had indication from Healthcare Research Wales that they'd like to support us financially going forward, so still working some of those things through, but worth flagging, we don't have core funding for this function, and I'm having to manage that risk amongst my other budgetary responsibilities. And then finally, commercial capacity has been a bit of an issue that we've escalated, certainly internally within the organisation. We have a bit more positive outlook, I must say, since the report was put together, because the DHCW commercial team have put some additional capacity in, and have got an approach that they're putting forward. So we're liaising with them. And then the commercial engagement team as well, which is part of a broader engagement function, they've got some plans in terms of, and they've actually produced a suite of documents, more to the point, around MOUs, letters of support, etc. So we're working out where we can, just use some of the standard templates, and there's enough intelligence, I think, within the team and maturity in this particular area, where there's some things we'd be very comfortable to take responsibility for, and then clearly where there's things that require more contractual input, etc., then we would need some specific commercial support, and that's the conversations that we're having with the team. So yeah, whilst that's flagged as a risk, it is and it remains, but we think we have a bit of a way forward as well. And I'm happy to pause there and take any questions.
Good. Okay. Any questions for Rachel? I know you've done an excellent job of presenting again, Rachel. Just one point of clarification for me. I was going to ask about the commercial risk you flagged, and I'm glad to see we've got some work around. I couldn't quite get from the paper what the root cause of the problem was. Have we got reduced capacity in the commercial team, or are they just overloaded?
I think it's just capacity within the commercial team, and I must say I certainly don't want this to reflect negatively on the commercial team, because I think they're just very overstretched at the moment, supporting a lot of things. So it's not that they've withdrawn their support, and
it's just there's a heavy workload.
I think just because the research and innovation work, and really positive ways, generating a lot of interest and a lot of possibilities. I think we just need to manage that against capacity of teams, and you know that goes for the likes of information governance, for finance, etc. So I'm very conscious that we need to monitor and be careful about what we accept, because it's not just about our capacity as an internal function, but we're very dependent on some of the corporate functions across DHCW as well.
Yeah, okay, great. Thanks for the clarification. That's helpful. Okay, I see no further hands up, so thank you, Rachel, for the report. We'll
David,
now... Yes.
I think Rowan had a hand up.
Oh, sorry, I missed that. Sorry,
That's
Rowan.
okay, David. Rachel, great work, and great to see the engagement around all of the outreach and sort of, in my world, business development, but you know, engagement that you've been doing with potential partners here in Wales, the UK, and in Europe is really great to see. I'm just wondering whether you can comment on not just the sort of engagement in interest in what we're offering, but also perhaps some of the benefits that you're seeing of having these conversations. I'm thinking particularly, you know, there's a big conversation going on in the EU around digital transition, particularly looking to boost the economic recovery and resilience in Europe, particularly health and care. And that is kind of reshaping thinking about you know, what is required, what people have the right to expect around their data. You know, is any of that flowing back to you as you're coming into these conversations, and how are you sort of sharing that across the organisation so that that can inform a lot of the conversations that we've kind of touched on in this afternoon with some of the reports we've just been hearing?
Thanks, Rowan. So yeah, I mean, from a personal perspective, some of those opportunities have been really good to kind of showcase and demonstrate what capabilities within Wales and digital health and care specifically, digital health and care Wales specifically. But absolutely, what we've been learning from partners has been just as interesting, and that they very much have been collaborative, where we've had a pitch and they've had a pitch, and there's been some joint conversations and learning, and I think, you know, there are obviously differences in healthcare systems and the way things are set up and the way we deliver data and digital services as well in Wales. So there are some big differences in that space, but I think there's some really useful learning and things that we're, you know, just having those conversations and opening the door to some of those broader collaborative opportunities is really worthwhile, in my opinion. And we are seeing, as I say, as a result of some of those engagements, we are seeing some approaches as a result, and people asking us to do their projects and their work within Wales, which is fantastic. And I've spoken at length about some of the broader healthcare benefits that brings for our residents. The fact that we have, you know, industry and pharmaceutical companies looking to conduct their research and looking to test their products here in a very safe and controlled way. I must say, I don't want to make it sound too experimental, but I don't need to convince you, Rowan, I know this, but as we know, you know, if we increase the opportunities for commercial clinical trials in particular, we know that will improve the benefits to the health of our population and the residents within Wales, and obviously all of the socio-economic benefits that come with that as well. So it's not just looking at health, it's looking at the economy. There's so many associated factors and things, and I think these conversations are eye-opening. I'm just very mindful of the size of that we are and some of the dependency things and constraints and things, and I've been having this conversation with the team a lot to feel like that's why we've been doing the engagement reflection and thinking, right, where do we tailor our conversations a bit more, and where do we want to pitch this, and we know there's some big things to resolve in terms of some of the legislative enablers and such. So, you know, we've got to be really careful in that space as well. But I will always set the ambition high, and I'm always looking to think about how we grow into that space.
Just a comment, if a comment, David, if you'll just indulge me on that. I think, you know, fantastic work with Rachel from Rachel's group here, because all of the academic literature shows that when you have research active health and care, it's great for the clinical staff to have that opportunity within their roles. It's phenomenal for patients, because patients who are on clinical trials tend to do better. And there are very, very formal reviews that people should be assured of that happen in order for clinical trials to take place. So to Rachel's point about safety, but the scale of the potential investment wrapped up in these trials would perhaps surprise some people. So in the last week, I've been having conversations with people who are talking about planning billion-pound trials for just one drug in one indication, and that having some of that money flow into our healthcare system to the benefit of patients and the wider service is really important. So Rachel, I commend you for all of the activity, and I think trying to, as we're hearing about risk, some of the things we've said today, the opportunity as well, just to balance those things. So I'll get off my soapbox, but well done, Rachel.
Thank you.
Okay, thanks for sharing your thoughts on that, Rachel. That's very enlightening. Okay, I can't see any more questions for you, Rachel, so many thanks for the report. And with that, we'll now move on to section 3.5 of our agenda, which is the section 255 request that we've received. And for this, I'll hand over to Darren Lloyd.
Thanks, David. So I'll be brief for this one. This is part of a component element that we've established with NHS Digidol, now NHS England, on the basis of requiring or requesting NHS England to perform certain tasks on our behalf when we're utilising their systems, their services, or sharing data, etc. So the component is section 255 that comes out of the Health and Social Care Act of 2012, which effectively says is an instruction to them to do something for us on our behalf. This is, as Rowan and David will know, this is part of kind of a sign-off process to understand that when we're instructing NHS England, whether we're instructing them correctly, and it's for the benefit of NHS Wales on our own organisation. So this one is an extension on an original instruction, which was around the digital services for patients and the public and the NHS app, and effectively the authentication services that we're using out of and in collaboration with NHS England effectively. And this is a small extension on that request in order to anticipate the further work that we're doing in DSPP and with the NHS app. As colleagues will know, we are moving quite quickly with the NHS app and with certain services within it, which means there's increasing reliance on aspects of those authentication services when citizens want to download the software and then authenticate themselves as a bona fide individual with access to specific data. So it means we just have to deploy a few more services out of NHS Digital and England's responsibilities to do those things as we move the app forward. So this is the next element of that iteration effectively.
Okay, thanks, Darren, for the background. We're being asked to ratify this request so that Darren and the team can send this to NHS England. So does anybody have any concerns about doing that or wants to ask any questions of Darren on this topic? Okay, I can't see any questions, Darren, so we can take it that this has been ratified and we're good to send the request through to NHS England when we can.
Thank you.
Oh, okay. With that closed, we'll now move to para 3.6 of our agenda, which is the cross-border ombudsman concerned. And Darren, you're taking the lead on this again, so back to you, please.
Thanks, David. Really, you might want to comment on specific elements of this, but this was us copied into the letter to the minister, effectively, in terms of some concerns around cross-border sharing of specific information flows or flowing of information, either from England to Wales or Wales to England, and some concerns about adverse outcomes and on particular patients in particular circumstances. I think it's fair to say we are really quite active in this area, not only looking inwardly into Wales, but looking outwardly and looking cross-border how we do share the data. There are technical components that give us some challenges, both in Wales and both on the England border as well. I think it's fair to say we have certain advantages within Wales where we do have some consolidation of information across our entire population. And sometimes we are pointing to a multiple points of entry, basically within English services, in order to try and technically share data. There are things that we are, like I say, we're doing within the expansion of the Welsh Clinical Portal, for instance, and allowing certain access to that data cross-border. And also some opportunities as well for us to extrapolate some information from England and bring it into our own environment as well. So indeed, myself and Rydian are in very early phases of discussing how we may have the opportunity to actually start to ingest some of the information from from England's National Care Record Service into some of our data sets. Very early discussions at the moment. We haven't got very far on it, but we can demonstrate actively that we are very active in this area to ensure that we're trying to minimize the impact of data and the flow of that data when a patient should move either from England to Wales or Wales to England. Whether their care in a secondary care establishment is over in England or whether some of their primary care services are in Wales, etc. And there's a lot of border elements to consider on that. So that letter is key for us, and as part of our strategy moving forward, as part of the DHCW strategy, overall strategy for Welsh citizens, and also advantages for obviously those that are resident within England as well.
Thank you, Darren. Rydian, did you want to add anything?
Yes, a couple of points, David, thank you. It re-emphasises what I often say, that failures to share information lead to failures in care. You've heard me say it before, and the role of Digital Healthcare Wales is to try and provide repositories of information that are accessible by any healthcare professional at the point of care delivery. That ambition is the sort of golden thread that runs through everything we do. And if we take the mantra, we need to collect everything from everywhere along the journey, we need to store it securely and safely, and we need to share it legally and appropriately. Regarding this particular case, I've previously met Michelle Morris, explaining what Digital Healthcare Wales can do and the role that they play in sharing information. I raised it at the Four Nations IT group, which John Quinn from NHS England, Dan West from Ireland, and Alistair Hodge from Scotland, and we discussed it in that forum about how we could work together to ensure that information follows the patient appropriately, including the ambition to deliver a UK-wide patient passport. I've also taken it to the All Wales medical directors, and it has been discussed there in the presence of DCMO, Chris Jones. So again, I've highlighted that this is something that we could deliver together, but it requires all parties to come to the table with a willingness to share. It's not an information governance problem. It's a cultural, behavioural, slightly technological, if I put my teeth back in, problem, but certainly isn't insurmountable. As regards to the comment Darren made, in my discussions with John Quinn, in access to the summary care, what was the summary care record in England, now the National Care Record as it's called, online is all the details about how to apply. We believe that we comply to all the regulation and bits and pieces that are on that checklist, and Darren and the team are putting that through. So that would help us get information from over the Severn, as it were, over Offa's Dyke into Wales. It doesn't answer the problem with care that's received along the borders, both acute care and also elective referrals to to Liverpool, to Bristol, etc. I think the way forward here is through the NHS app, the ability to provide the documentation from secondary care and the summary care record from primary care for the patient to hold wherever they go. That comes with some advantages in terms that they are the data controller. They can do what they like with it, and share it with whomever they like. So there are a number of things that we would try and put in place to mitigate the risk. I'm not entirely convinced this risk will ever go away as people buy different systems that don't integrate into the various things that we need them to integrate into.
Right, thank you, Rydian. Actually, Rowan's got a question.
Well, to be honest, Rydian just sort of touched on it right at the end there, which is,
Okay.
you know, the full mitigation for this issue is not entirely in our hands. You know, in Wales, we've made a commitment to open architectures and systems. You know, there is a practice in some of the larger, for example, electronic healthcare record systems, whereby the providers of those systems tend to hold that data within their system, and it's quite difficult to get it out into third-party processes. So, you know, if another member of the Four Nations went down that path, or Wales did in the future, it tends to be the thing that makes addressing this risk more difficult. So, I think this issue is one that is important for us to discuss for two reasons. One, the issue that the Ombudsman is highlighting specifically today, but also as a reminder, when Rydian's not in the chair saying a failure to share is a failure of care, that sometimes we make choices that hamstring us in the future. So really important that we keep our commitment, I believe, to open standards and open architectures, because it's our best defence against this.
Rydian, you want to come back in?
Yes, I just want to make a point that that I was copied into the letter. It was for the ministers of England and the Health Minister or Cabinet Secretary to answer. I have actually provided Helen Thomas, our CEO, with my outline of advice, and I'm aware that the Cabinet Secretary has been advised by her team.
Right, thank you for that update at the end there, Rydian. So we've been asked to discuss or note the correspondence and have a discussion around it, which I think we've done. So unless there's anything else on this particular topic, I'll move us on to the section called Deep Dives today, and for that, Darren will take the lead, but bring in Cora as required. We're going to do a deep dive on the IG Toolkit and the Data Protection Officer Service for primary care. Over to you, Darren.
Thanks, David. Yep, Cora's on the call. Cora's the DPO service and IG Toolkit manager for these two services. So another part of our main component of our IG framework. So we'll take them in turn. For us, and Cora, I'll just provide some narrative and maybe just go into a little bit of detail where required, so I won't crash the party too much. The aspect in terms of the main components of the kind of IG framework has kind of got its DNA from about 10 years back, in terms of the fact that we're nearly 10 years old on measuring some good IG compliance. Some of that was born from some of the development in the Caldecott area, the Caldecott principles, and some are more obviously development in terms of changes of legislation as the driver in terms of what good compliance looks like and the need for a toolkit. Other administrations have toolkits as well. We know that England have their own version of the toolkit, Scotland similarly, and other home nations. But we've moved the iteration of the toolkit onwards. I have to say it's been there's all of the IG components are a challenge because they're never at the forefront of priorities. They're never seen as the sexy component of an organisation. They're part of the assurance model that Rydian will know this. There's a battle in order to get them understood and the importance of the understanding within organisations, etc. But I've been happy to take that element on and take it forward because myself and the team have known these are really important elements to actually consider, because they do give the assurance, and information does not get shared on just one element. There are multiple elements that come together with the dynamic of getting data from A to B. The trust and the assurance is a massive component of that. And the toolkit is one of those big components from my perspective. So the toolkit is within our responsibility. It is outwardly facing, but of course it's inwardly facing as well, because I've previously just talked to you about our own compliance with that particular facility. So we are lucky where a lot of the development has come in-house, and I'm looking to Sam and his team there, and thank you in terms of some of the aspects operationally as well, in order to bring what we've created as a platform for the toolkit in-house to give us some flexibility on what we needed to do, putting the emphasis on the toolkit and the IG element within that. There are other components as well where we have toolkits, and England's toolkit a lot more comes from a security perspective, but we have some of that tasked as part of our other systems and services, previously in Jamie Graham's remit and now within Jamie's replacement's remit. So we're moving through the journey of the toolkit. We have a new iteration on a new platform, again with thanks to Sam's team and the application design guys, working closely with them. And creating an opportunity now to develop the toolkits, because we have more places that we need assurance from. As we move the model, as we move the assurance requirement across into other services, we need to measure them in terms of compliance. Rydian mentioned that, again, we've mentioned the fact that putting more data into other organisations requires all of these component parts to come with it. So as it currently stands, we have the toolkit, and it applies to health boards, trusts, and special health authorities like ourselves, currently general practice, and community pharmacies more recently. But we know the journey is not complete, and we need to accelerate that journey in some respects, because we have optometry, dentists, prison healthcare services. As part of our API management element needs to take into consideration what assurance might look like from a commercial perspective, those type of things. So the acceleration of the toolkit is really important to how we move the strategy of the rest of the organisation forward on open forums and open data as well, and that data sharing element. I'll stop there. There's kind of the journey set within the paper, and I'll just let Cora come in and just say a few words about the excellent management of how we've actually moved that forward over the last couple of years.
Hey, thank you, Darren. Thank you all. As Darren says, I am the DPO. I'm Cora Suckley. I'm the DPO and IG Toolkit Manager. Darren's covered a lot of the journey that we've been through. It's just to reiterate that the Welsh Information Governance Toolkit is the framework, self-assessment framework organisations in Wales currently complete, those organisations being health boards, trusts, SHAs, general practice and community pharmacies currently. Wales has been on that journey, as Darren alluded, since 2015, and the most recent journey started in around 2020. And that was based on the fact that the platform that hosted the toolkit at the time was no longer fit for purpose. We didn't have the capacity to cope with additional stakeholders, which halted that framework rollout at the time. So as an organisation, we undertook investigation appraisal of various options, and it was agreed, as Darren's mentioned, that the Application Development and Support Directorate would provide resource to develop a new assessment tool and platform. That programme and development work started in around 2021 and has been ongoing since. I have to shout out to the DHCW development team. They've been fantastic, and they've been working really, really closely with the ID Toolkit team to develop and build a platform in a staged approach that enabled us to go live and test the ID Toolkit, but also to develop additions that were needed in a timely manner. So we launched with version 1 in test in February 22, and we've had various iterations in April, version 2 in April 22, version 3 in July 23, and version 4 in October 23. We're currently on version 5, which we launched in February. And all of those versions have contained some iterations and update to the platform to help our users of that platform in completing their toolkit submissions, with some of the key developments being things like the development we call parent and child relationship, and that was implemented to support the onboarding of pharmacies. Pharmacies are often, quite a few of them are in big groups, and they wanted to complete once for many, so we introduced tooling to help with that. As I say, we're on version 5 at the moment. We've still got some work to do to finish our initial scope of build that was set out all the way back in 2021, and we do have commitment from the team to support us with version 6 and version 7, with the version 7 timeline to be completed by the end of this year. And that would then see us encompass all the original build requests that we had and all the functionality that we needed for a really, really robust platform. It's important to note that the platform is being used by the ID Toolkit team, but it was also used by other stakeholders. So other stakeholders that have been using the previous platform, Form Builder, have also started to migrate onto the CAFOR platform and utilise it for other assessments. For example, dentistry has moved over to complete some of its clinical governance assessments. So in parallel to all of that work that involves the testing and development of the system and working on all of those features, the team do a fantastic job in that space working with our developers. We also looked at taking the toolkit itself and the question set on a journey. So when it started, as Darren mentioned in his update on the organisations position, it used to be a level 1, 2 and 3, and you had to meet a certain kind of level. We've changed that assessment in this toolkit, so we now have a minimum level of requirement that an organisation should reach, and then you can go into expectations exceeded, but you won't exceed expectations completely unless you've met all of those minimum requirements, and those minimum requirements are set on key important factors that the ICO and others see as the key risks for organisations. The toolkit question set is built on the ICO's accountability framework because that is the golden standard of assurance. It was piloted initially, so we piloted the question set and the platform with health boards, trusts and SHAs in January 23, and then we took lots of feedback and we also consulted with general practice at the time. And completed a revision and a release of version 2 was then undertaken the following year in July 24. So everybody went live for the first time then. In July 23. In September 2023, we also did some work with the Data Security and Protection Toolkit team in England to align some ID toolkit adequacy, so for general practice and community pharmacies specifically. And that comes with the cross-sector and cross-border working that we're now experiencing across a lot of our programmes of work. And this hinged on the requirement for community pharmacies and general practice to have access to the NHS England spine, which facilitated the EPS or electronic prescribing programme in Wales. So we worked with the DSPT team or Data Security and Protection Toolkit team in England, and we gained the adequacy agreement that both toolkits were equal for those, so you can complete either a DSPT or a ID toolkit in Wales, and that you would be able to have access to the NHS England spine. So that was a huge piece of work that was really successful. Work is still ongoing, and it is noted as a risk in the paper that we've provided today, that of alignment between the two for larger organisations, so the health boards, trusts and strategic health authorities. This is because, as Darren mentioned previously, that the Data Protection Security and Protection Toolkit in England has a real cyber focus, so it's based on data security standards. The ID Toolkit in Wales is based on information governance. So we are looking and exploring with our cyber assessment unit colleagues the alignment between Welsh processes and assessments done in our CAF assurance processes against our English Data Security and Protection Toolkit to try and provide that assurance for those larger organisations. That work has been slightly hindered because England have just announced or going through a huge revamp of their Data Security and Protection Toolkit. So as we were sort of getting somewhere, they're going to throw that up in the air and make a lot of changes. So we've just halted that for the moment to assess what they're going to do. And I have been working with England Data Security and Protection Toolkit colleagues to understand those changes and try and future-proof the Welsh ID Toolkit against them. So we're currently undertaking that journey with the view to hopefully establish larger organisations adequacy as well, equivalency between the two in later on this year. Pharmacies have then subsequently onboarded to us with version 4 of the toolkit in January 2024. and that again was to support that electronic prescribing programme and those requirements. Health Board Trust, Strategic Health Authorities General Practice Toolkit closed on the 31st of March, so just over a month ago now. And the new toolkit has been made available as of the 5th of April. So it closed. We had a very short period of time where we migrated everything over. And the real great thing about the new toolkit is that once you've completed it the first time, those questions link. So the data transfers through and you have to just re-review it and accept it. So that's a real benefit for our users, which wasn't there previously. And the deadline now for next year's assessment is the 31st of March 2025. Pharmacy Toolkit remains open until the 30th of June. They were given slightly longer to complete because it didn't go live at the same time as everybody else. However, again, the plan will be to close that and then reopen that by the end of the first week of July, and then with a closure date of the 31st of March to then realign everybody. So each year we're opening in April and closing in March in the same cycle. In addition to all this work, we were also approached by our Welsh Government colleagues, Pharmacy Welsh Government colleagues and Community Pharmacy Wales to support them with the Clinical Governance Toolkit for pharmacies. So we've also launched that on the COFOR platform. So pharmacies are completing both their toolkit and their Clinical Governance Toolkit in the same space, which they find really useful, and we're supporting them going forward. The team has done an extraordinary amount of work in this space, dealing with over 2,770 contacts alone just on toolkit queries, so supporting people getting access to the platform, getting access to the Clinical Governance Toolkit. That's the journey as we are now, but we don't stand still, and as Darren mentioned, our developments continue for 24, 25 and beyond, but this year we've got a focus on onboarding some new stakeholder groups. So our key priorities there are prisons, our optometrists and our dental practices, and most recently we're having conversations around onboarding kind of third-party organisations into that process as well for assurances linked to API management. We will, although we've just released the new question set for this year, we'll also be on a consultation journey with all the relevant stakeholders. So we release a question set and then we start a consultation on what next year's is going to look like. So we'll be consulting with all of our stakeholders. We'll be looking at legislation changes or anything else that's coming out, ICO recommendations, what feedback we're getting from stakeholders, along with what happens over the border with the DSPT. And then we will be coming up with our revised 2025 question set to have that agreed, assured, signed off and ready for release from the 1st of April the following year. Our platform developments continue and will continue this year and beyond as we get support from the team. We've got clarification support for now for those version 6 and version 7 builds, and we'll look at what other additional support is required after that on whatever progress we need. All progress and developments are overseen by our ID Toolkit Service Management Board, which formally brings together all our key users of the ID Toolkit and enhances our communication and consultation with all our stakeholders. So we have all our key stakeholders represented on that group, and that group will grow as we add more stakeholders. The committee is just asked to note the information and any questions.
Thank you, Cora. Any questions for Cora? Sam, you've got your hand up.
Thank you, Chair, and thank you, Cora. So as Senior Information Risk Owner or CIRO for DHCW, I just want to say thank you. I recognise the amount of work that's gone into this process, and it's a really important piece of work and a framework for us to have in place. So I just wanted to recognise that. I think it's important for us to understand how we're using the returns that we get, both the one that we complete for ourselves and for stakeholders across the system, to actually then drive improvements in information governance posture across NHS Wales. So I'd be keen to understand more about that in due course. And then the point you made at the end about alignment with the Cyber Resilience Unit, I think is important. And I think there's a real opportunity there for us to align both the IG and the cyber posture and the work that they're doing on assessing against the Network and Information Systems Framework. What we're doing here with the IG Toolkit, I think, yeah, we should absolutely explore that and align as best we can.
Thank you. I completely agree. We are working, we're more than happy to re-engage and once we've got the DSPT updates and look at how we work on that cyber assessment and resilience element and linking in our NIST work. I think that's really key. In terms of reporting, we have had some functionality issues with the Toolkit platform, which has hindered some of our reporting requirements, but that is hopefully, fingers crossed, that fix is being deployed overnight, I believe tonight, and then once that's been tested, we'll be able to confirm more on the reporting side. We do get basic Toolkit reporting at the moment, i.e. who's completed and to what level, but we haven't shared that widely yet, just because we wanted to double check and test that a bit more before we did. Organisations are given, or certain groups of organisations are given, more detailed reporting. So, for example, in pharmacies, there's a legal requirement for the health board to have access to those submissions. So all of that data is fed back to the health boards for them to work with their contractors to drive compliance. And then the other element that's really supportive is things like confidentiality advisory group approval is using the ID toolkit as the mechanism for that approval in Wales. So they will be coming to us. They come to us at the moment and ask for the assurance that an organisation has met the minimum standard. That also links into a number of our programmes. So, for example, the electronic prescribing programme, organisations cannot get access to the spine unless they have met that minimum expectation. So again, we're providing reports. As reporting develops in the system, which is part of our developments, we will have more interactive information that will be available and more readily available to the public to check an organisation's status, that they've met those minimum requirements.
Thanks, Cora. Darren, you've got your hand up.
Just one small matter, David, in terms of that continual look at compliance, in terms of where things change. There's a new data protection bill on its way through. There may be some narrative that we change as a result of having to change, hopefully, not any main components in terms of what the law says, but we know, because we know it's broadly aligned to what we've got already, but the narrative might have to change on the language within the toolkit. So we're continually testing, as Cora said, against a lot of areas to make sure that we've got the right approach to our assurance model.
Good to know, Darren. Thanks. Ridian.
Thanks, David. A couple of things, really. IG is everyone's business. That's the first point to make. The second point is we've got a fantastic team at Digital Healthcare Wales who are leading Wales across this. That's credit to Darren and the likes of Cora, who are working in partnership with the health boards to try and help them do the right thing in the least painful way. So I'm very proud, actually, of the way that we've led in this area across Wales, and will continue to do so.
Really good point, Ridian. Thank you. Any other questions for Cora on the IG framework? Okay, I did have one, Cora. Under the risk section at the back of your paper, you did raise, I think, a little concern about developer resources. Is that still a concern, or have you and Sam managed to resolve that?
We have now resolved that for version 6 and version 7. I think there is still a small potential risk going forward that any future developments will still require some developer resource, and we'll need to plan that in to our workloads as, going forward, because this isn't something that just sits still. So, but yes, for 6 and 7, we've got the committed resource requirements. So that's been updated since the paper was written.
Fine. Okay. And Darren, we're back to you, or with Cora for the next bit?
I'll provide some of the front narrative and steal Cora's thunder a little bit, as usual, no doubt, and then she'll probably come in and give a little bit of detail. So that seems to be the model.
Okay.
Again, another very important part of the framework. The inception of GDPR, of course, gave question in terms of support for that, the understanding of requirements across the law, those type of things. So it was, again, another kind of a 10-year journey, slightly less than that, but a 10-year a journey around what organisations do to support those smaller organisations that don't necessarily have the resource to understand what their compliance requirements are through things like GDPR, etc. So I was sat in a group of information governance managers many years ago, with some demands going, look, we need to support primary care. We need to support primary care with an advice and guidance service to make sure that they are compliant in specific areas of information governance, because they are a key component of delivery of services and information sharing elements. And at that point, when everybody said that, they looked at me. They looked at DHCW whereas previously in order to help to support a service that provided robust professional advice and guidance to general practice. So born out of that was the DPO service effectively. The funding model was not secured. The funding element was in doubt. So what we had to do was spin up a levy service effectively. So with that we charged a very nominal amount to provide this service to general practice, advice and guidance on complex matters, a resource bank of information, and then, funny enough, information governance toolkit audit service in effect to actually go through the toolkit with individuals to see how high or how low those levels of compliance under those specific areas. So again, another real big component of the IG framework, and something that has come from demand inside the service. And again, MWIS and DHCW has reacted to that demand because we see the framework as being those component parts that Rydian made reference to earlier. The team has grown in order to help provide some of that advice and guidance, and I think it's fair to say now that we are getting into pretty deep, complex matters and queries that we're actually getting around interpretation of the law, interpretation of information sharing and shared information through primary care and and GP practices as well, helping to be that middle element through conversations with the Information Commissioner's Office should there be any elements of consideration and any complaints back to practices, etc. And I think practices see this now as a big mainstay of part of their arsenal in order to demonstrate a fairly good level of compliance. Let's just say some are better than others, and other practices then seeing that they can rely upon something with a professional service to actually to use. And some practices use the DPO service quite a lot. Because they're large practices. As we know, practices are kind of communing a little bit, and we have large super practices, so they use a lot of our service on any number of different in any number of different ways. I'll just stop at that point. The other aspect to say that because of the success from the DPO service in general practice, and because we're delivering the toolkit in community pharmacies, we're now looking to expanding the service, the DPO service, and the advice and guidance into community pharmacies. So one generates activity in the other that we find, so that the whole framework element comes into play. So again, we have to think very hard on how we actually develop the resource for the service and how we develop the funding and the model for that, so that we're not putting significant amounts of risk on the business, but we have a sustainable approach to actually providing this in the longer term. And that again is a testament to how we try and develop our models of funding and resourcing these type of things.
Okay, thanks, Dan. I can see Marilyn's got a hand up. Marilyn, do you want to come in now or after Cora's spoken?
I'll come in after Cora if that's okay. Thanks.
And Rowan?
Just a quick one on funding, Darren. We've just talked about information assurance in optometrists, dentists, prison healthcare. Will we also be offering a DPO service to those types of organisations? Has that been discussed?
Not,
or is that...
I wouldn't say not in any detail, but I would anticipate that question probably will get raised as we move the toolkit and we move other components of the framework onwards, because that advice is likely to be warranted and required to some capacity. So, like I say, one comes with the other one, and so I would anticipate that question will be raised at some point in time in the future. I'll let you come in now, Cora. Sorry.
Yes.
Okay, thank you, everyone. So as Darren sort of said, we started this journey back in 2018 in May, where we were asked to provide an independent data protection advice and support service for general medical practices across Wales. The whole purpose of this service model is to establish an all Wales approach to GPs, providing that consistent level of advice support to those practices who choose to subscribe. Each practice who subscribes does pay a levy fee for that service, which funds the service provision, essentially the staffing. That funding is ring-fenced, and it was agreed that that would be a not-for-profit service, so we don't make any money off of GP subscription. It covers the cost of the employed staff within that service, and covers all of that service requirement in full. And currently there are the equivalent of about 5.5 full-time members of staff that run this service. So we currently support around 83% of all practices across Wales. The remaining percentages, 6.5 of those are health board managed, and around 10.5 obtain their services from elsewhere. So they either subscribe to another service, or they have an in-house DPO, and that's entirely up to them. Our subscription spans all 7 health board areas and 61 of 63 clusters. So we have some involvement in all clusters bar 2. The 2 clusters we don't are North Wales based clusters, where a private DPO service is heavily prevalent. So there is more, I would say, competition in the north from the private service, although we have had some organisations come over to us from that in the last year, mainly based on back of toolkit resource provision and support that we're providing. The team processes and responds to around 2,500 to 2,600 action point contacts a year. I think it was 2,542 in 23-24. Those contacts can range from simple support calls, but as Darren alluded, we are seeing many more complex requirements, and which can be anything from complex projects and data sharing initiatives, data protection impact assessments. We've got some innovative stuff with AI, practices wanting to look at AI, Amazon type locker for medicines, pharmacy dispensary type services recently. So lots of varying stuff comes in on that service. The last year, the team have done quite a bit of work. They have redeveloped and redesigned the entire training provision. So we have developed individual rights, Caldecott, Guardian, FOI and EIR training. Those have been redeveloped and they were rolled out in around October time last year, and that was to support the new IG Toolkit framework and support practices with the minimum training requirements that they need. So we deliver those sessions. We had around 540 training bookings were confirmed, and that was 294 separate individuals across those 3 training modules. We've recently released data incidents and breach reporting training in March. That started rollout. We've got some really positive feedback on that. Additionally, in addition to those bits and everything else that we do on a day-to-day basis, the team launched some specific toolkit support sessions. So this was the first year that the general practices had their toolkit in full to do, and on the new platform in the new way with the new questions. So we launched support sections that covered each of those 10 different workshops. So each 10 sections of the toolkit, they were super well received by practices. We've got loads of really good feedback, and we had 1,641 attendances across those workshops. In addition, the team continued to develop its entire website content. We've completely revamped our subscriber website and our support information. The team produced 43 dedicated new resources to assist practices in meeting their new IG Toolkit requirements, which included 11 policy and procedure templates, 12 guidance training videos, those 3 training packages, and a range of templates, logs, and guidance documents to help support them. Other key developments of the service last year, we completed a training needs survey with our service users. So before we went out and delivered lots of training to them, we asked them how they wanted it delivered. Did they want it face-to-face? Did they want it virtually? And we got their feedback. It's them that require the service. And we developed all of our training and resources in line with what their needs were to meet the needs of those individuals. We established a service management board, which includes all the key stakeholders to review and agree the development plans and priorities. As I said, we redeveloped and relaunched the entire DPO website. We developed a significant number of animated training videos because, again, that came back on our feedback was actually bite-sized training videos were really helpful. So we've got lots of animated videos to support with general awareness. We developed a general IG information governance general awareness e-learning package that's on the website for them to use as well. And then we conducted a communication survey to establish how our stakeholders wanted to engage with the service going forward and what they were finding worked well for them. So does the newsletter work well that we develop and deliver to them? So we've completed all of that work, and then as we move forward into 24-25, our priorities are to launch some further training sessions. So we are starting to roll out in the next month basic information security for practices, so talking them through their basic information security requirements and things to consider, and information sharing, so how we can support them to open their doors a little bit more and be a bit more open to that sharing, making them a little bit more comfortable with that. We are completing ID toolkit audits. So we go out to practices after the toolkit is closed and we say to them, right, do you want some support to audit your responses? And we've started those. We've had around a third of practices ask us to audit their toolkits this year. So the team are working through around about 30 to 40 each audits to look at what practices were submitted and whether that meets the standard and give the feedback. In response to that communication survey, we're going to implement a request a callback form because we're finding that a lot of things are being done by email, and actually sometimes they want to speak to people, but we're not always sat at the desk with a phone these days. So we're implementing a callback request form, and the team will be able to contact and call those practices back. We're providing targeted support for practices, so looking at our less engaging practices and seeing what it is that they would benefit from for our service. We're piloting some DPO support drop-in sessions. A cup of tea with IG, I think, is our kind of strap line. They can come and have a chat with us, ask us anything they like in those drop-in sessions. We're completing some privacy audits. We've come across some issues on the back of complaints and some of the work that we've been doing with the ICO involvement with general practice and the privacy information. So we're going to do a bit of privacy information auditing. We'll then look to develop the ID framework audit for 24-25, next year's talk, or what is now this year's toolkit. We're continually reviewing and updating website resources. Then we will be looking at developing further plans and kind of feedback from our users to inform our 25 and 26 planning. And then additionally to all of those things, as Darren mentioned, we have been approached by pharmacies to look at expanding a DPO service to pharmacies, which we're currently scoping with them, just finalising, and we'll be looking to launch hopefully very soon. And again, we will have to then go through that whole iteration of support packages and the information and make that support pharmacy specific. So there'll be a hive of activity in that space to launch and support with pharmacies, and likely other stakeholders as things move. We're more than open to taking on additional services as long as the organisation is clear and supported those decisions as and when they occur based on the funding models that we develop. I think that's it from me. The committee has just asked to note the information.
Great, thanks, Cora. Thanks for that comprehensive overview of the service you and team are providing. Has anybody got any questions for Cora on the Data Protection Officer service?
Sorry,
yeah,
mine was just more of a comment really from earlier on, really, just to say that thanks for the information. It's been really comprehensive, and also I think this is a typical example of what goes on at DHCW, like Vivian alluded to earlier on, that people don't know about. There's so much really good work they're doing, and some of the case studies that you talked about were very detailed and very comprehensive. So, you know, the work that you're doing is absolutely phenomenal. And I did have some questions, but to be quite honest, you answered them all in the information you've given. So thank you very much for that. And as I said, I think that, you know, we need to do more of telling people about the good work that's actually happening within the organisation behind the scenes, that they get to actually be able to do their job much easier because the services we're providing is helping them, supporting them to do that. So I think, yeah, thanks for your team, and thanks, Darren, for the feedback as well, both of you. And as I said, we need to do more of this to let people know, really. Thank you.
I'd agree with that, Marilyn. Robin, you've got your hand up.
Yeah, just to say, this is so impressive. We've now got this sort of very scalable approach to assessment, compliance, support, training, which actually gives us a real advantage, you know, and it builds upon WASPI and some of our other IG capabilities, particularly now the level of maturity across the whole of the health service in Wales that can be achieved through DHCW support is really outstanding. Look forward to seeing the journey on the path to the ICO piece, Darren. I think that's magnificent, and you know, don't just drop in for a cup of tea with IG. You don't need to risk it. There'll be a biscuit, I'm sure. So well done, everyone. That's phenomenal. Thank you.
I would agree with that. Thank you, Rowan. Darren.
Just quickly to say, we're doing this in partnership as well. Cora has kind of alluded to that, but it's not just partnership with our customers in terms of GPs, etc. This is in partnership with the Information Commissioner's Office, BMA, GPC Wales, or CPW, Community Pharmacy Wales. We have to. This is the only way to do it, because then we are taking individual organisations on the journey, and those that are helping and are component parts and representatives. It's sight seen, it's transparent, and it means that we get that partnership approach to things. We can't do it on our own. We have to have that level of partnership approach across all those different organisations to make sure that the sponsorship for this is we've got the right element to it. And the Information Commissioner's Office have been key to this as well in terms of promoting some of those services we've had, because they recognise it as good compliance. And in the unlikely event that the ICO does have to come into these organisations, them knowing that we are a component part of some of the assurance actually allows those organisations to have a better conversation with the Information Commissioner's Office, not a nasty conversation with the Information Commissioner's Office. So there's a huge partnership approach to this, and it's thanks to the relationship that Core and the team and the wider information governance team have actually built up across the years, and that is one very important facet of this.
Yes, thank Darren. I think it's even more impressive the range of stakeholders we've had to liaise with in order to get this off the ground. So well done to both of you for that. Before we move on, any last questions for Darren or Cora? Nope, done a great job, Cora. Darren, thanks very much both for the deep dive. Really excellent session. I'll move us on now to closing matters. First item is any other urgent business. Nobody's raised anything in advance of the meeting, so can I just check if anybody's got anything? No, I can see no hands up. Next item then is the Chair's highlight report. The only two things that I've noted, which I'll share, is the good news on the NIAS and the WASPI funding, which has allowed the overall risk profile of what we're overseeing to have been reduced, because we've had no new risks, and we've obviously reduced two down to a directorate level. And I think the other point I'd like to highlight is the one made by Ridian, which is the excellent work we're doing in this area of IG Toolkit and the DPO service, and the fact we're collaborating with the health boards and in fact leading on it, which really lends weight to one of our strategic missions, which is to be a trusted strategic partner for NHS Wales. So those are the two things I'd noticed. I probably noted but then dismissed the technical debt discussion that we had on the basis that everybody knows we've got some financial challenges. So really, there's not a lot of point in highlighting that, and unless anyone disagrees. Those are the things I had on my list. Has anybody got anything else that they would like to add? No. Okay, great. Thank you for that. The date of the next meeting is Thursday, 15th of August. Rowan will be back in the chair, and I'll resume my role as vice chair. We are running slightly ahead of schedule. Oh, Chris, sorry.
Sorry, David. I think you're going to come on to it. It's just about starting the project. Do you want to come on to it? Thanks for the prompt. I was going to do it anyway. We are running 15 minutes ahead, so I suggest what we do, unless anybody's got any problem, we'll break for 15 minutes and then start the private session at 3:30 rather than 4:45. Okay, see you all. Sorry, Rowan.
Just very, very quickly, David, I think I should just ask that we highlight my thanks to you for covering while I've been on sabbatical. So thank you very much. I really appreciate all of the coverage and that you've enabled me to do that. So thank you.
Okay, thank you, Rowan. Okay, thanks everyone. Meeting's now closed, and we'll resume in 15 minutes for the private session. Cheers.